In the human body, the liver has two venous return systems. The hepatic venous system drains the venous blood from the liver to the inferior vena cava, and the portal system, which conveys the venous blood from most organs of the gastrointestinal tract and its associated organs to the liver. Hi, this is Adel Hajjai from the Anatomist. In this channel, we are helping medical students to understand and enjoy human anatomy. If you are new here, consider subscribing. The portal system drains the venous blood from the lower third of the esophagus down to the upper half of the anal canal. In addition to that, it drains the spleen, the pancreas, and gallbladder. It's valveless veins, and it is approximately 2 to 3 inches long and conveys about 70% of the blood to the liver. The remaining 30% is oxygenated blood passed to the liver via the hepatic artery. The portal vein is formed by the union of the splenic vein with the superior mesenteric vein behind the neck of the pancreas at the transpyloric plane at the level between the first and second lumbar vertebra. It obliquely ascends to the right side to enter the lesser omentum. Then it ascends anteriorly to the epiploic foramen up to reach the porta hepatis, where it is divided into two main branches, right and left branches, just before entering the liver. It's posteriorly related to the first part of the duodenum, common bile duct, and gastroduodenal artery. And in the lesser omentum, it lies posterior to both the bile duct and the hepatic artery. And it's related anteriorly to the inferior vena cava. The main tributaries of the portal vein are the left gastric vein, right gastric vein, cystic vein, and posterior superior pancreatic duodenal vein. The variation of the portal vein usually involves the right branch of it. Thus, the right branch is absent in about 10 to 15% of the people. In this case, the portal vein trifurcates before entering the liver into left branch, right medial sectoral vein, and right lateral sectoral vein. This unusual arrangement affects split liver, therefore this might be considered a contraindication for the live donor liver transplantation. Normally, the venous return through the portal vein traverses the liver and drains into the inferior vena cava through the hepatic vein. Nevertheless, there are other smaller communications between the portal system and systemic system. The locations of these communications can be summarized as: first location, at the lower third of the esophagus, the esophageal branches of the left gastric vein anastomose with the esophageal veins that drains the middle third of the esophagus into the azygous vein. Second location, at the lower half of the anal canal, the superior rectal vein drains the upper half of the anal canal anastomose with the middle and inferior rectal veins, which are tributaries of the internal iliac vein and internal pudendal veins respectively. Third location, the paraumbilical veins anastomose to the left branch of the portal vein with the superficial vein of the anterior abdominal wall. Fourth location, the veins that drain the ascending colon, descending colon, duodenum, pancreas, and liver anastomose with the renal veins, lumbar veins, and phrenic veins. Portal hypertension is a common clinical condition, and the main cause is liver cirrhosis. When scarring and fibrosis from cirrhosis liver obstruct the portal vein, the blood pressure rises in the portal vein and its tributaries, and is frequently accompanied by a congestive enlargement of the spleen. At the anastomosis sites between the portal and the systemic veins, portal hypertension causes enlarged varicose veins, leading to backflow of the venous blood from portal circulation to the systemic circulation. Back to anastomosis sites that we mentioned before, we can make an assumption what the clinical presentations will be. Hematemesis, bleeding esophageal varices, develop portal hypertension resulting in dilation and varicosity in the veins anastomosed at the lower third of the esophagus. Varicose esophageal veins may be ruptured, causing severe vomiting of blood known as hematemesis, and this case is very severe and may be fatal. Rectal varices, Following portal hypertension, the rectal veins at the halfway of the rectum dilated, forming the rectal varices. Portal hypertension has often been mentioned in relation to hemorrhoids. However, an article published in 2019 mentioned that the hemorrhoidal symptoms do not occur more frequently in patients with portal hypertension than in those without it. I will leave the link of this article in the description below. Caput medusae. After portal vein obstruction, the superficial veins around the umbilicus and the paraumbilical veins distended massively. Distended subcutaneous vein radiate out from the umbilicus, producing the clinical presentation referred to as caput medusae, which means head of the medusae. Dilated retroperitoneal veins. The venous flow back after portal vein obstruction heads to the retroperitoneal veins near the hepatic and splenic flexure, and to the other veins that drains into azygous, hemazygous, lumbar, intercostal, and phrenic veins. Clinically, dilated retroperitoneal veins are very risky during surgery and intervention procedures. The treatment of portal hypertension may involve creating anastomosis of the portal vein to the anterior wall of the inferior vena cava, behind the entrance of the lesser omentum, helping in that the direct relationship between them, as it was mentioned in the beginning of this video, and the management known as portocaval shunt, and the communication might be side to side or end to side. If splenectomy was necessary, in this case, the splenic vein might be anastomosed to the left renal vein in a procedure known as central splenorenal. Thank you so much for watching this video, and if you like it, don't forget to hit the subscribe and the like button, and let me know in the comment below if you want to discuss a certain topic. See you in the coming video.